next talk is by Dr. SAVARI DESAI, and as you can see, these are her credentials. So as they say, good things come in small packages. So over to you, SAVARI.
Thank you, Anand. And I'd like to thank Anand, what started from him as a germ of a thought. We realized we've actually learned so much from each other, from this entire whole concept. And we all knew, but now it's kind of spilled over and we've learned from each other. And it is really, I feel, enhanced smaller things in our practice. So I'll be talking on careful cosmesis, or basically safeguarding in oculoplasty. आपका लगाओ ना, आपका ट्राई करो. ये नहीं है, आपके पास नहीं है, मैकबुक के लिए नहीं है. तो लाइए ना, सब हॉल्स में है. So I want to thank Dr. Sugandhi, is our NABH principal assessor, and the legal team which handles. So after starting, so basically I do oculoplasty, oncology, orbit and aesthetics at Hinduja, and when we started like 14-15 years ago, the medico-legal part of it was something that I really learned along the way. So what do we need to know? So, in Europe, America, everywhere, there's so much litigation and so many cases on basically aesthetic surgery, and oculoplasty has now basically overlapped aesthetics. So this is some of the terms which we've used very loosely, but I just thought, just for people who are just starting out, don't know exactly what they mean, and this is literally from her mouth. So negligence is basically when accepted protocols and accepted procedures of the specialty, which are considered kind of like gold standards, supported by textbook and articles, and the association are not done, is considered as negligence. Then litigation is when someone feels, or the patient feels, there's undercorrection of a surgery, failure to meet desired results, unwarranted complications, or not explaining, which is what we've been talking, which finally leads to compensation. So as we've been discussing clinical evaluation, and we just took a question on documentation. So even in oculoplasty, this is how we document. So this is a sebaceous gland carcinoma. Now, the thing is, when I started document, we were all taught in our institutes. And then one day when I had documented and the papers went scanned and they wanted it for just simple insurance purposes, the patient came back and told me, ki, I think, doctor, you didn't mention this. So though I think my drawings are very, very thorough and are almost textbook, what the insurance raised, though it was not a litigation, that this was not mentioned as was done in the surgery. So was it actually there? Now, it was a very small thing. But what it made me do is that if you're going to draw, then draw properly and label everything. You don't need to take a sign from the patient, but you need to then document everything. And if you're not going to do it, then that basically doesn't give you this gray zone. So you need to document it thoroughly, make a note that you've documented it, because otherwise it can raise this thing that, was it possible that this was not documented? And this is the same patient. So this is just show you how we sort of draw the diagrams for eyelid, conjunctival, whatever, oncology and aesthetics. So in oculoplasty aesthetics, it's really tricky. So this, which is done by cornea, refractive and all of, is okay, but not when you put it into perspective, because then you're revealing the face of the patient. So it becomes very tricky. Now again, here it's it's a sebaceous gland carcinoma on top. It's a scar below. Fine, this is nothing. You don't need really photography consent or worry about it. But when I'm showing patients thyroid eye disease, you have to basically take a consent. So again, full face. So now what I've started doing, even in conferences if possible, is putting a watermark. So try and make your own watermarks. You don't need any fancy technology, and put it, especially if you're revealing the face, or then cover up the eyes. But often you want to show it, like is seen in this patient. If I cover the eyes, then the purpose of showing that he has a ptosis gets lost when in teaching. But even before all this, we document a lot of the stuff, not just the photography, but what we're going to advise. And we've spoken about this. So here, this is my handwriting, and I've actually written, discussed with patient regarding patient may have possibility of 2 surgeries. So I sign, and this I take a signature from the patient that on the OPD sheet. And initially, I think when I was initially I started, we were a little like, I think when you're new, you're just kind of like a little apologetic कि कैसे पूछने का. Now I don't feel apologetic at all. I just kindly explain to them and I say, नहीं आपको sign करना है, please read it, this is what I'm writing, and you're most welcome to take the xeroxes of these papers from the MRD department. And we encourage them if you've taken, so that they know that whatever is being signed is transparent. So this is what we do. So these are the counseling notes and the signatures. So going back to photography, now this is an IGO article by Mukherjee et al. By Dr. Bipasha. Excellent article which basically talks about external photography or face photography. It's an IGO, easily available freely. So it basically talks, and this is the actual consent given, and I use this, but we've translated it in Hindi and Marathi, and we have it so the patient, and it's easy to incorporate in a private OPD also. Basically we have copies of this, so when the file is made, the photography consent is put along with the sheet, and as soon as the patient comes, we don't immediately take a signature, but if I've finished my evaluation and I feel that yes, we're going to have to take photos, then I counsel it and I said there will be a small consent. And there's a thing in this which it says that basically, unfortunately I have not put it, where it would maybe used for publication, academic purposes, okay, so or for teaching purposes and things like that. So some patients do ask that, will my photo be used in a medical journal? So we say yes, there is a possibility. So some of them outrightly say no, we don't want it. So then I just make a note that patient, no for academics, like that, just no for academics. So that means that basically it's not that you can't use it, but I would refrain that, because the footprint on the internet is so long lasting that you want to be a little careful that if this patient is absolutely not wanting it, of course things like models and all who are very prominent, we don't even encourage putting it. Coming to a surgery consent which we were talking, this is our consent for exenteration. The reason I've specifically chosen this is, of course there's ptosis and there's DCR and all those, but when you're doing morbid surgeries where it is almost akin to an amputation, like enucleation, evisceration, exenteration, there are a couple of things we run through. First, 2 consultants advise the same surgery, especially enucleation, evisceration. If there is no 2 consultations on paper, along with a vision evaluation, we don't go ahead with the surgery. When we do this, this is a one we've modified from the AIOS consent and some international consents and made it. So here it's written basically blah 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 tissue, the type of procedure contemplated, and then here it's written that, okay, I state that get this in the form of this surgery. So if besides this I feel there is anything else that I want to add, there is one line that says additional comments if required. Can you see this, what I've circled? So here there is space for me to write whatever else I need. So though in this consent it is specified that even after removal of the entire socket or eye, you will not have vision and only a prosthesis will be put, and prosthesis will also not have vision. If there's anything else, we put it here, and then there are 2 signatures, not just here, but here mine and the relatives and or the patient. The reason Hinduja has always added, but we've added this into the exenteration consent because it brought us, especially in the COVID mucormycosis crisis, we got alarmed, and especially I got alarmed because it was rampant. We were doing exenterations like in the middle of the night, in the morning, and we realized that it was like Ashish said, it was a gun to the head. It was like, you have to do this, others patient will get cerebral mucor, or we have to do this. And we started saying that, we started putting there that though exenteration is being done, there is not necessarily thing that patient will not progress to a cerebral involvement of mucor. So those were things we realized that we had to make a note of, because itna sara we can't put in a consent form, because exenteration can be done for varied things. So it gave us that little flexibility legally to actually write what we wanted and countersign it. Now coming to, these are some of the photos. So the other thing when we were talking about counseling is, this is an out and out aesthetic patient, which is a blepharoplasty patient. So was fine. We had to take different photos. Now in our thing, documentation, photographs, whether I use it or not is so important, because in spite of counseling after this is immediate post-op. So she knows, she was expecting this, but when the bruising is so much, they're a little alarmed. Now she knows she was going to have bruising, but then the apprehension is so much when they actually have it, you know. So now, maybe not like now, over the last 4 5 years, there are certain patients who are okay about showing their photos, and I show the sequence. So I have a little PDF which says 1 week, 2 weeks, 1 month is your recovery, because it usually takes 3 to 4 weeks for aesthetic patients, no social gathering. So this was something I realized, that I used to just counsel them, but I realized, like ptosis, where there's lid lag and lag of thalamus, it's better to show even aesthetic patients that you may not have so much bruising, but this is the extent you can have, and this is the time duration. So the minute they started seeing photos, I stopped getting frantic middle of the night calls or getting messages, that, oh, I think my bruising has increased. So I would encourage, it's more like a patients who are doing like full face and aesthetic procedures, but it's a good idea to have this. Coming to consent for experimental and research, of course you have your your review board, which will have specific consents. So if we are doing any sort of studies, then that is involved in counsel the patients and taken. So basically what we are told is that be part of associations. It's very helpful because they support you, and you sort of have a more of a thing that yes, you are part of an association. So insurance, we touched upon it a little bit, but this is really what I've got from her horse's mouth. It's based on what you do, but it's also on the number of years of practice. So the more you practice, the higher your insurance should be. I, of course, was being very sort of, not wanting to take an insurance. Still, one of my insurance person said, you have oculoplasty, though it's not plastic surgery. He says the minute oculoplasty comes, now it's changed, and I had to just jump up my insurance and had to go into cross, because they said, since you're doing aesthetic procedures, though you don't have the plastic thing, because it's oculoplasty, you have to be covered, and I had to go for the whole hog and do the whole insurance thing. So documentation, like we spoke, 5 years is good, but 10 years is the best. Now I'll just put in one last slide about this, the Pandora's box that I call WhatsApp pictures and consultation. Again, for cornea, this, that, it's okay. But then we have patients sending WhatsApp for eyelid and things like that. So this was something we did when we were doing teleconsultations along us, after asking her. And this was kind of some of the words that we had to use, like this telephonic is granted to you upon your request. So we were told that if by any chance you do a WhatsApp consultation, put these disclaimers and get a thing, say, yes, I want a consultation. Of course, we do it dime and dozen for friends, family. Ye drop dalo, wo drop dalo, ye karo. It goes. But if you're doing an official consultation, I would encourage everybody to, pass a disclaimer post that. So finally, I'm ending it with this. So this was published. It's actually an oculoplasty sort of litigation, and a review. And they basically spoke about, they reviewed from 1988 to 2012 oculoplastic surgeries which has undergone malpractice issues. So the commonest, of course, was blepharoplasty in 63% and brow lift. So both aesthetic. But, it was also followed by things like ptosis. So what was the people who were actually, the defendants? Plastic surgeons, okay, 46 of them, but comprehensive ophthalmologists and fellowship trained ophthalmic plastic surgeons was 17%. So as the awareness increases, these cases also go up. And look at what the reason was: lack of informed consent and need for additional surgery, which is why I put that thing where I wrote that may require 2 surgeries. So these are little things over the years even I have learned. So this actually really brings it home that consent and counseling is what you need, and you need to countersign it. So oculoplastic surgery is now sort of, merging and is overlapping with plastic surgery. So just ensure yourself and know your legal implications. Thank you.
Thank you, Savri. Are there any questions?
No,
If
plastic
not,
surgery, nobody wants to. We'll stay away from that.
So we'll move on to the next talk. Yeah, that's right.
As you showed in the pictures that we have to tell the patient regarding that post complication, any kind of thing. In such cases, like the average ophthalmologist like us, the patient may run away to some other field.
No, no, you don't need to show such drastic ones. I've shown you this is the this is the fourth day post-op, and she was on blood thinners, but I didn't get into the details of that. But I think you can show some amount of bruising. You can show. It's not a question of running away. Once they've come to you, you will gain that confidence. And like I say, अगर patient आपके पास नहीं आ रहा और भाग रहा है, then maybe that patient doesn't need to be in your. No, it's not that. No, it's not that every So, I actually have reached a stage where I would rather say that this is something that you may get depending on the texture of the skin, what medication they are on, diabetics, hypertensives, blood thinners. Not everybody gets this. She was on blood thinners, and I told her from day one that the minute I touch you, you're going to get bruised. And she was fair. But I think now I've reached a stage where we have been able to get that patient confidence. This is just one of the things I said that you can show. It's not mandatory to show, but I feel more comfortable showing certain things that this is the sequence because patients ask it. They say, how is it going to, how is my recovery going to be? And then sometimes they say, can you show us? So we just say that, itna ho sakta hai, itna ho sakta hai. So I think it's kind of like refractive surgery. The next person will also offer you the better deal or the thing, but eventually it's your thing to convince the patient.